Welcome to the PD Exchange podcast, the Peritoneal Dialysis podcast where we discuss the best publications in peritoneal dialysis. I am your host, Dr. Nikhil Shah, a nephrologist at the University of Alberta in Edmonton, Canada, and with me as always is my co-host, Dr. Jeff Perl, a nephrologist at St. Michael's Hospital, University of Toronto, Canada. Dr. Perl is also the editor-in-chief of the journal Peritoneal Dialysis International. We are coming back after a hiatus on this podcast again, and today we discuss the latest position paper to be published in Peritoneal Dialysis International. It is the Teaching Peritoneal Dialysis, a position paper for the ISPD. And to discuss this key topic, we have the authors of this paper, Drs. Josephine Chow and Dr. Anna Figueiredo. I will request them to introduce themselves.
So I'm Anna Figueiredo. I am a nephrology nurse from Brazil, and I'm now the chair of the nursing and allied health professional of the ISPD.
Thank you. And Dr. Chow?
Yeah, I'm Josephine Chow from Sydney, Australia. So I'm carrying a very exciting role for the ISPD Standards and Guidelines Committee as a chair. And I was the past chair for the Nursing and Allied Health Professional Committee.
Well, I want to thank Josephine and Anna for being on the podcast today. I also am doing a shout out to all nurses to join the ISPD because, as you can see, we have a lot of important information and education to share, not only with our nephrologists in the PD community, but all of our allied health and our nurses. And so today, I think we have something to discuss that's very much in the nursing domain. And, I don't think that there's anything that comes as important to our patients as trying to train them and teaching them peritoneal dialysis, because as we know, they're doing this therapy at home independently with or without a care partner. And I think launching patients into home peritoneal dialysis with proper training is really important. So I think this document is incredibly important because it provides a little bit of a blueprint and guidelines, not guidelines, but a position paper on teaching peritoneal dialysis. So let me start off with you, Josephine, as the first author of the position paper. Can you tell us, these have appeared in PDI before in a different format, and this is really an update of teaching. What do you see as new in the guidelines that you want to highlight to our audience?
Thanks, Jeff. First is I want to acknowledge all the contribution by a co-author like Anna. Anna has been actually with the three versions or generation of the guideline or position paper, or we call the guidance, all right? As what you say, the PD nurse is so important in successful training the patients, supporting the patient at home safely and prevent complication for PD. The ISPD provided these guidelines back in 2006. Now it's 2025, the third generation. So this paper really expands what's suggested by preparing the patient for PD. So we actually divided them into PD dialysis, and then we're doing the training, education intervention element, and then also emphasize about the PD post-training as well, and all the home visit, the multidisciplinary approach to enable the patient, empower the patient safe at home. So that's very different from build on to the past and build on to this position paper.
Right. So you just summarize that for us, the main differences?
Yeah, the main differences is actually we build on the adult learning principle. Unfortunately, that's the only evidence around for training, and build on lots of P dialysis training, assessment, the PD training assessment, looking at the preference, looking at the home environment, health literacy, the preference, the learning style, and then also put a bit of a competency assessment, and I think emphasize about like 24-hour support from the PD team to the patient when they actually gone home. Touch base a bit of the retraining, unfortunately, we only find from 21 article, we only find for randomized control trial, and it's a lot of critical analysis around those evidence as well. So we can actually really put very strong emphasis on that.
And so that's really great. So it sounds much more comprehensive. I'm going to ask you, Anna, what do you think is the most important point to get across in the guidelines? If you had to pick the most important thing to relay to the readership and to our nursing and training colleagues, what would that be?
It's quite difficult to point out one main difference.
I know, that's why I like to ask the difficult questions.
So I have been involved in the 3 previous position paper guidelines, and we have a slightly different approach. And I would say that this new one is more inclusive because we have the pre-assessment, the training, and the post-assessment, while the 2 guidelines before were mainly talking about how to train. The syllabus would give you day by day, so you would exactly like a recipe, know what to do. And here we see it's a broader way to look at the patient. It's not only training, but what should we do before and after this patient has been trained? I think that's the main difference. We see the whole process, not only the training for the competence of doing PD or connecting to the machine or exchange the bag.
Most important take-home point?
Most important take point is the nurse is the most important take point. We should prepare the nurse to train. I think that's the most important. We should capacitate our nurses and the best way to train.
Right. And so do you think that so someone is going to read these guidelines and how would you approach a new nurse that's starting PD that has very little training experience, that are going to read your guidelines as a background? How would you train a nurse in best practices? What would be your approach to sort of onboard somebody new in PD nursing? Again, using the principles of the position paper, but how do we actually take this document and actually translate it into being able to put it into practice? Any things that you think have worked well in onboarding new nurses in your program, or that you might provide as tips for new nurses?
I think for the new nurses, the most important thing is find a mentor. If you have a new one, the new one is not only doing the procedure, is how to teach, how to pass the information. So observing a more experienced nurse doing the training, doing the approach would be great. So having time for these nurses to be able to be with another nurse doing the training, observing how other nurses do the training before they go on and do the training, and then be supervised by this mentor. Because it's not one moment. You have to prepare these nurses step by step how to move for being a novice to be an expert. And it takes time, and people don't realize that it maybe take longer than 6 weeks. That's the time in average that we have to train nurses, but it's much longer than that. The 6 week will be only be okay, you can start, you can do your first patient, but it's much more than that. I think finding a mentor, someone that is more experienced in training patient, would be the first step. And of course, having all the theoretical basis of adult learning, being creative with the material you're going to use, that will help a lot.
Yeah, so I think it is very important to be mentored, and for a nurse to have a relationship with somebody senior that they can feel comfortable with, to learn from. So you talked about adult learning, and that's a theme that comes across the entire guidelines. Sometimes it's a little bit tough for us to understand. Josephine, what would you like to highlight about adult learning principles? Maybe introduce us to the concept. And what does that actually mean?
Yes, so adult learning principle is not a new thing, all right? So it's actually a term very popular since the Malcolm Knowles times, 60s. how they just describes how adults really learn differently from children, and then acknowledge and respect the individual that they bring lots of their prior knowledge about adults and how they process and apply the information. They self-directed, they use prior experience, they goal-orientated, they really doing something like relevancy and really want to do. So if we got that principle in mind, which is I totally agree is like really conceptual, but it's how to apply that is really interesting. The whole thing is we shouldn't be treating everybody the same with the same standard recipe. So not one suits fit all. But teaching in PD technically is not just teaching exercise. It's not just a technical exercise. It is the relationship to build between the nurse and the patient, all right? And there's a partnership and how we as a nurse to attribute the trust, empower, and then basically build the patient autonomy. And also using the adult learning principle, recognizing this value, core value of respect, and not treating them as a kid, and also get them active participation. Knowing what most important for their life to do PD, maybe it's actually because they want to attend the daughter's wedding in 12 months' time. That will be a good motivation to keep them going. And then we're doing something, unfortunately, we got another jargon called the patient-centered approach or people-centered approach. It's really important we using our knowledge to wrap around the patient and build the patient's confidence and build into competencies and enable them to actually do the PD safely and independently at home. So, so that's what, empathy the nurses always have to build around that. That's a bit unique for nursing. It's about empathy, understanding that.
Yeah. I'm going to turn it to Anna and say, I'm still sometimes a little bit vague about like a concrete example of an adult learning principle and how to apply it to training. Can you guys or Anna think about like an example where you might want to do it this way, but here's how you would do it in a different way when it comes to training? Just so our listeners can maybe think about exactly like bringing an example to life in a specific aspect of training.
Okay, let's see if I can explain it. I used to say that no one wakes up one day and say, okay, let's do it. I'm going to learn PD today. Okay? You get the disease, you need to learn it.
Yeah.
And most of patients don't want to be in this position at the time. So finding out which is the motivation for them to carrying out their life, to continue their life, is the first thing that we can apply adult learning. See, why you're going to be here? What is your motivation for life? You want to, like Josephine has said, attend a wedding. Okay, let's do it. How are you going to manage to be there on your daughter's wedding, whatever is your motivation? That's one thing. The other thing is trying to see how is going to explain peritoneum for one person. You trying to see if they have an experience of rural life, or if they understand some of the principle, like brewing a coffee, how it works. So make some experience they may have in the past that can help them to understand the concepts you're passing on. Because we know it doesn't matter if you're a high education level, if you're illiterate, you can understand some of these principles if you relate to your past experience. So it's more a way that understanding the patient and which are the motivation, what's important, treating the patient with respect. Like, it's not, oh, poor patient. No, it's someone that is needing to learn a new skill that wasn't prepared and he needs it to live their own life. So it's applying how you are going to value, respect you, although I need to teach you something new. I don't know if it makes sense for you, Jack.
I think, if I could summarize my understanding of what both of you have said, and maybe this is just me not getting it initially, it's framing it so an adult who's dealing with a therapy that, quite frankly, they're not jazzed about starting. I mean, who's excited about starting dialysis? Getting them to understand or get a motivator for them that will allow them to be interested and engaged in the information that we have to relay to them, and in the skills that we have to teach is one aspect. So I think that's helpful. I think as we move along in trying to understand this, more concrete examples are really helpful. Like, I think it would be, and I think, Anna, you've said this before in previous position papers, the guidelines are only as good as we translate them and we provide examples and we teach and we do webinars. I really think here we really need to see this in action with really great examples so that we can really bring it to life. I think it's very challenging with training guidelines to really put onto paper what you have to see, what you have to do, what you have to feel. And I'm really hoping that we get more material and more nursing education that allows us to be able to do that.
I'm just going to quickly chime in and say something. It's almost like an experience when I have an experience of this adult learning being applied by the nurses. What has happened is like Jeff said, that what is the actual event? A patient who started dialysis was not comfortable and not training fast enough, as we would say, it was delaying. And then the doctor that day came in and said, oh, he is not able to comprehend what you are teaching, but if you write it down for him, he will understand it so much better. And immediately the switch occurred about the adult learning from a hearing perspective to a visual perspective, and the training was quickly done. So I think understanding that and applying that initially, as you mentioned in the paper, is probably a good idea.
Which is a good segue into discussing VARC. So maybe, Josephine, you can tell us what VARC is and talk to us a little bit about learning styles. I think Nikhil probably gave a really good example.
Yep. Yeah, so I call it education intervention, or in a way that is actually more confusing nursing stuff, because we used to actually doing things such as the nursing practical stuff. But if you it's a cooking a dish of a delicious dish. You need the ingredient about that. You need the environment. You need to assess the patient prior to understand their learning style. Whether it's like Nikhil said, basically whether they are the visual person, whether they are the practical person, need to be hands-on, whether they are combined, and then also configuring about their background to the language, the cultural sensitivities, and also the belief and the goal of wish as well. So all those need to be assessed. And then the health literacy, which is, I think, is very challenged as well, that they speak really fluent language doesn't mean that they can read or they understand what the technical and medical terminology. So if you actually do all those assessments well beside the scenes, and before we actually design the care plan and the pathway how we train, but bear in mind that will change with the situation as well, with the cognitive ability, with environmental factor, with some medical condition, that situation may change as well. So it's an ongoing assessment is so important to make sure that we enforcing the teaching and then the learning process for both of them.
Yeah.
So with that question.
But I will say, and I'm going to get your guys and Anna's feedback about this, that in my experience, and tell me if you guys have had the same experience too, we sometimes bias patients on not being able to learn. We judge patients, unfortunately, and our bias is, oh, they're never going to be able to learn how to do home dialysis because of health literacy. But I've been, many times again, surprised and delighted to see people are able to learn and they are able to do it. But, sometimes it's our very educated, sometimes with a medical background type people that we're training that come in with this attitude, well, I know how to do this. This is easy. This is no problem. And they're actually even more challenging to train because they're not willing to accept what your information you're providing to them. So I want to get your viewpoint. Like, health literacy can kind of go both ways. And I think the assumption is that, low health literacy can't learn, but I think that's wrong in some cases. I think in some cases people come in and you have to sort of get them to trust you and start from, square one, and they may not be so ready to accept that. Have you guys had that experience in your programs?
Yes, definitely. And I would like to put something. First, going back to VARC, I think VARC would be useful for everyone,
Yeah.
mainly for nurses, to assess how I learn, because the way I learn is different than the way Jeff learned, and I have to adapt to your way.
Oh, that's
We
interesting. So
use
VARC for
like
the patients and VARC
because
for the nurses. Right.
because I'm a very motor person, okay? But I
Yeah.
cannot assume you're going to learn the same way. So I have to understand how you learn to
Yeah.
adapt my way to teach you, because it would be different than my learning. I think that's one of the issues that we should suggest people to do. Everyone should understand how they learn
Yep.
and
Yeah.
then be able to teach.
Do you
And the
think that,
other
do you
thing
think,
is,
can I just ask, can I challenge you on that? Do you think you think everybody can be boxed in, or do you think some people are combination, like within VARC, like visual, auditory, kinesthetic? I think like when I think about me, I think I like have to hear things and see them and move around. Like I feel like I don't know that I box myself into one particular area. I feel like I kind of
but
have to do a hybrid. What do you think?
you're not boxed. You have a prevalent one, but
Right.
usually you use the four styles to learn. But there is one that is easier for you.
Yeah.
I'm a motor, as I said, but I like to write things down. Even if I'm not going to look at my notes again, but when I'm listening, I'm trying to write it down. So I'm not just one style.
Yeah.
We usually learn the four styles for different situations
Right.
that we have in life.
And let me get
And
your
the
guys'
other
feed.
thing,
Oh, sorry. Go ahead, Anna. Sorry. Go ahead.
no, go ahead.
No. I was going to say one other thing I was going to ask you guys about. It was it's really interesting. A lot of people have talked to me recently about group training multiple people at once. I want feedback from you guys about that. And what are your thoughts about that?
Yes. So Jeff, to start with, there is definitely no evidence or high certainty evidence around training one-on-one or group. Even staff to patient ratio, there was really, unfortunately, it's not strong evidence around that. Group training will be good to in a way that we do refresh or retraining with a set topic. And that's what in the position paper in 2025 update, we actually suggest that the retraining with different topic rotating, because we found out that some of the literature found out that it's very hard to get the adherence of the patient to come and for those training, the group training, and depends on what group there's some people are more interested and they will prefer not to actually disclose too much of the information or share, and they don't learn really well in the groups training. It's good for generating innovative idea and support, and also it's good for time management for nurses. When they're too busy, they can actually group them together. But logistically, it's very challenging. And that's another really good research topic that if anybody embark into that. But for the retraining, it's really good idea.
Right. Like, me, I'm like sometimes dominate the conversation. So I could squash somebody else who was in my group, right? So I might not be the right person to do group training with. So I could see there's a lot of dynamics there, like who's in the group. There's a lot to think about. Who's in the group, how many. But I do like the idea that if you're doing retraining or a refresher, what we did in our program is we kind of did it as games. We like brought the patients in and it was like games and quizzes and all sorts of, we kind of made it fun when we were kind of doing an infection prevention retraining in a group, but it was retraining. It wasn't training for the first time.
And different people learn different pace and different situation that will change their pace of learning. So it's challenge, but we also train like 2 patients at one time for some topic, but not a structured training group training session.
Okay, another controversial question I'm going to ask you guys. So two controversial questions, because this is what makes it fun here. One, are some nurses, trainers, and others don't possess the skills? Is it something we can teach, or is it something despite any amount of teaching, sometimes somebody might not be suited for it. You guys as nurses have to wear many hats. You have to be able to train patients. You have to follow the patients, help with decision making, help with prescriptions, do PETs in some programs, do adequacy, collections. Not in my program, by the way. That's a podcast for another day. But you guys do a lot, right? And so, in a perfect world, are there nurses that, if they're good at training, should focus on doing that, and others structure a program to do more longitudinal care and clinic and that sort of thing? Or is this everybody should do it? Everybody should be good at it. Is that really feasible? I'm just trying to get at this. And maybe this is opinion, not evidence. But you guys are obviously tops in this area, so your perspective would be really interesting. If in a perfect world, how would you structure things? Do you think everybody can do it because everybody can learn it? Or you got to understand that some people are going to be better than others, and we should leverage those skills and leverage people's strengths to do what they're good at. Again, controversial.
Yeah. So
Well,
Jeff,
let's start. We want to start,
tell
Joanne?
me?
Go on.
Yeah. All right. So Jeff, I don't do too much of the PD patient training nowadays, but I do quite a bit of training for nurses and midwife and JMO, particularly doing around research and evidence-based and implementation science. I believe that people learn different pace. Not everybody, it's like a job. Not everybody is suitable to be a chef, all right, or musician, or a doctor, or training nurses. So you need to have that passion around what you want to practice. And I quite use some looking at like the Clinton strength to look at what your strength is in real life and try to match the team together. So it should be a multidisciplinary approach. People support this patient or support the program together, and then we'll make successful. Not just nurses, but even PD nurse. PD is actually predominant by PD nurses, but the medical stuff like yoga will be very good to support it. It's no strong evidence around that, but I don't think everybody is actually suitable to be a trainer without the support. And then it all depends on what their career pathway as well. Training patient is totally different. We don't learn the certificate for adult learning principle training. We should, all right? But it's another chapter, another podcast about workforce development planning for nurses.
Yeah, Anna, what's your perspective on this?
Well, I think everyone can learn how to teach, but not everyone can teach. You have to have the passion to teach. Think about how many professors do you have that are the best in their field and they don't know how to pass the information. It's the same when we're teaching. You can be the doctor, PhD, whatever. You know all about adult learning. But if you don't know how to communicate, you're not going to be able to teach. It's not only theory, it's the passion to pass on the information and feel the needs of the patient. So everyone can learn, but not everyone can teach patients. That's my is opinion based, as you well said, is opinion based.
Yeah.
And I have experience with very good nurses that I at first thought, okay, she'll be good. She likes working with the elderly. She's the perfect for PD, and she did it well. But she came to me later and said, I don't like it. I prefer to be doing hemodialysis than being here teaching the patients. And
Right.
she was good, but
but even in but here's the question. Yeah, so that's very true, and thank you for your honesty. But does every PD nurse have to be a teacher, or can it be something that some of our nurses in our program specialize in teaching? On the one hand, if we had specialized, subspecialized teaching nurses, for example, those patients might longitudinally be looked after by a different nurse. And I've always thought that the initial connection during training really sets the scene up for a really important nurse-patient relationship. But, what do you think? Do all PD nurses have to have that passion for teaching? Is that something you think is important?
Yes, I do.
I do, and particularly to keep the continuity of continuum of the care. So because the patient is not just come for surgery, they've been with us for the lifelong, years, months, and then they build a relationship around that. So the trainer follow up ideally, and the communication among the team is very important because nobody actually really doing 24/7, 7 days and cover the patient. So ideally, the ideal world will be the trainer continuous primary care with the individual patient, and then build the trust so the patient will be really honestly and tell them when before they got put into trouble.
Yeah, so
But,
I think
So,
sorry, go ahead,
Jeff,
Nikhil.
I'll just quickly tie this up a little bit in what I have experienced in my unit.
Yeah,
Is how the patient is allocated to a team of 3 or 4 nurses, of which one is the primary trainer, and then continues. And they are the ones who, like Jeff, you said, very passionate about that teaching part of it, and they're very good at it too. And then the others are helping out with the troubleshooting part of it, and when they are drop-in and stuff. The other thing I wanted to highlight was many times it would be just kind of closing out on the health literacy part of it and the patient. Many times I would have gone into the clinic and I would have said, this is going to be tough, patients learning and all of that, and the nurse would actually say, we've taught this patient only for 4 days, we do not know this patient as well, let's give them more time. And I think that is one of the most key feedback that I receive when we are making how long and how difficult it is. When the nurse makes that connection with that patient in the first few days, they will figure it out on how best to teach this particular patient and this particular group, because it is sometimes not just the patient but the caregiver, the family member, who's also the support person for that elderly person who's on dialysis. So I think that communication on both sides is excellent.
yeah. I'm going to add to that, and again, ask you guys a question based on what Nikhil said. And I've experienced this as a physician. Listen, I have a certain style of communication and the way I interact with patients. Hopefully that style works with most people, but my style may not work with everybody, and I may not be optimally communicating with everybody. And so some patients and physicians might get along and communicate better than others. And I always encourage people to be with the right person that they feel comfortable with and can communicate with. Do you think that do you think that we do that enough in PD training, that we figure out, maybe this particular relationship isn't working and we should think about switching it up? Do you guys look at that in your own programs, and would you suggest that we do that? Like it's not, we're not saying that the person's not teaching. It's just sometimes there's a connection, and sometimes there's not, and it's hard to get through. And rather than keep persisting, maybe a switch up with a team member might be useful. What are your guys' thoughts on that?
Yes.
Oh,
So Jeff, yes, Anna, you go first. Yep.
No, I was just going to say that I have a few examples in the past that we have like 2 nurses doing the whole PD, and then junior nurse came to me and said, I don't know what's happening. He cannot learn with me. Why don't you try? And exactly as this, she was clever enough to realize that whatever she was doing wasn't working with this specific patient. And we changed the approach. Okay, I was more experienced. Maybe my approach was different. I could understand better. But we managed to teach the patient because we realized that something was lacking. The training wasn't progressing as it should be. And then we changed it. It's perfect. And she was a very good trainer, so it wasn't her problem. But as you said, the connection there. And the other thing I want to say is about how the nurses have this feeling. I don't know, you in the high-income country probably don't have as much experience of training illiterate patients. We have a lot of illiterate patients, and they can learn as fast as anyone if you use the right tools. You're not going to give anything written to them. Everything has to be spoken, drawn. So it's a different way to teach. But we have to separate illiterate than not being able to learn.
And that's
they can.
That's a great point. And on that, I want to pick up and say, what other tips for training in low and middle income countries would you suggest that we think about? So you talked about modifying our style based on literacy. Anything else that you want to point out to our listeners from low and middle income countries that is particularly relevant to them?
One thing is we don't have evidence of home visits before training, so we're not advocating it. But we need to understand what is the home environment of the patient, because when they are training at the hospital, they will have tap water, they will have different things. And you see some places in Colombia, they just teach patients to prepare their own gallon of water, to clean their hands. You're going to give the same information, but with the resource the patient is able to get. So understand how the patient lives and which conditions they have makes a lot easier the training. It is valid for everyone, but in the low income, maybe their difficulty are not as yours, the same as yours. So you have to be creative.
Yeah. And I will say from experience, we have started to systematically do home visits before patients start. And even in high income countries, we do encounter challenges with people who are hoarders, who are on, have very challenging homes. And I think that is also really important. And you came back to it in the beginning, talking about it's not just about the training, it's the preparation for it, it's the post, it's the follow-up, it's a comprehensive look that the position paper is taking. So that's a really good point.
And Jeff, can I add on to that?
Absolutely. Yeah, sure.
Yeah, the position paper for the 2025 update is different. I look at that, analyze that for the last two versions, because we try to make sure that we got representation from North America, Latin America, Europe, Asia, and Australia, New Zealand. But we also individually go to Africa, talk to a couple of nurses, the patient and consumer, to try to cover all the geographical low and middle income country practice, because we put down something like ideally 24/7 support by the PD team post PD training. It is not realistic in a lot of country with that resources, but we don't put it in there. That means we don't put it there as a evidence recommendation. We put it as a practice tip, good to have. And then we need some more research to prove that it works. Yeah, so it's really important when we develop the guideline, then we need to actually make sure we're inclusive for all those elements, to cover all those differences.
That's really, really important point. Couple more things I wanted to make sure that we covered. We have more technology at our tools than we ever at our fingertips than we ever did before. In 2025, do you think that we are leveraging technology to train patients? How can we? And do we have any insights into that? Virtual training. A lot of people have talked about like sort of simulation training and that sort of thing. Anything technologically that we can think about to sort of advance our approaches to training? Josephine, any thoughts on that?
Yep. All right. So on the position paper, we actually also look at the technology, the VR, the simulations, and some of those work. I know it's not for today, but artificial intelligence is there, is here for us. All right. So as long as we know how to use it and integrate it that nicely, virtual training is another way that we've been doing it. We're pandemic, we pop up all this telehealth, virtual teaching, and lots of unit actually keep using that to make sure the patient can follow up. And then remote monitoring with either the vendor related, and we just got another paper coming out as well about remote monitoring. What's that mean, and how compliance nursing staff and patient use it as an enabler. Yeah, so I personally thinking that we need to actually open our mind and open the usual aspects of about doing training and utilizing those technology enable and empower the patient and the nursing staff to support the good outcome.
I think virtual reality is there. Fresenius have some steps of the training in virtual reality. I don't know why we don't use it more. I don't know why Vantive doesn't have more on that, or any other company, because that's the way forward. we are not excluding the nursing, but we're making nursing time of quality of nursing time. The time when we're going to be with the patient, we're going to be there. But the things that he can memorize, the things he can play with beforehand, can be done with virtual reality or remote monitor videos or whatever. So we are not using the full potential that we have in hand. I hope very soon we're going to do more about that.
Yeah, and I completely agree with that. And I think, I mean, this is another discussion, obviously, where how to incorporate technology overall. But the training, when we keep insisting about how to train, the training should not stop when the unit closes. The training can continue with technology at patient's own pace, at home, at their leisure. And it can be with their own care group along with it. And that can be, like the videos and the virtual reality. Or it can also be something like an AI chatbot or something that can be incorporated, vetted, so that we understand what information the patient is getting and it is under guardrails. And I think it is the next step to go.
I also think I would also extend that and say we're not leveraging technology enough to audit our training and to refine our training. I bet you that if some AI tool was listening to the training taking place, it would be able to provide feedback in areas for reinforcement during the training that perhaps it didn't hear us talk about or cover or demonstrate. You can imagine at the end of the training, it says, you didn't talk about a wet contamination with your patient.
Yeah. And Jeff, what Nikhil talking about chatbots and all that, I already got a virtual midwife finished training, finished modification and research. So it's about antenatal. So the same principle can be actually definitely built in. So the patients, they are in the middle of the night, they're doing APD. They don't need to switch off APD because they can't reach a nurse. Yeah, but we're not replacing nurses. But that's again another chapter, another podcast in the future.
The only thing I can give an analogy to, and it's not a great analogy, is driving a car, right? But and again, this stays up with us, and I guess everybody who's listening. But in the old days, when you reversed into a parking spot, you turned your neck, you looked at the window or your mirrors, and you moved back, right? And you parked into a spot. Nowadays, we look at the screen with all the positions of the cars around us, and we look at our screen and the beeping and because we want to park safely without an accident. And I say, that's how we're going to move with PD in the future. What we're teaching now, in the future, we're going to have technology that's going to be challenging us in the way we tell people how to do things, because there might be different ways of doing it, even more safeguarded with the addition of technology. So it's challenging here because the technology is evolving and our training has to evolve with the technology.
Right?
Yeah. So I'm going to give you guys a theoretical question here, switching topics. A lot of this is as obviously we don't have robust evidence in PD. So a lot of the position paper is, of course, as you said, Josephine, there are some randomized trials, but we need to do more in the area to generate more evidence. In a magical world, I'm giving you each $5 million to do the randomized control trial in patient training of your dreams. This is your dream trial that's going to impact outcomes. And you think, and I know Josephine will probably have you on to talk about Teach PD in the future. We're getting close to that. Again, a podcast for another day to talk about Teach PD. So don't say Teach PD. But what is your future dream randomized control trial?
So, Jeff, if I got $1 million, I would love to actually keep the passion that I have when I did my PhD on the P training suitability assessment, the JPEG, about assessing patient for the suitability for PD and home HD. And also, I think it's an element about...
so what's the randomized trial? In one group, you're doing what? And in one group, you're doing what?
One group doing actually built into the JPEG is a Peritoneal assessment tool or whatever assessment tool in the world that we can actually repair it, adopt it, and into the new intervention. Then one group will basically just do the pre-training assessment, continue assessment, and then see the outcome with the placebo group. So that will be, I think it's very important to prepare them well enough, sort out all the problem, and then keep monitor them in a way that we can actually pick up the problem, whether it's social, whether it's mobility, whether it's medical, and then to keep continuously giving the good support to them. Because at the moment it's blinded, all right? So we wait for very reactive approach, not proactive approach. When the patient turn up.
Right. So a systematic assessment, that's the intervention. And we're going to look at the clinical outcomes that the Song PD group has set forth for us to look at in that randomized trial. Again, a podcast for another day. Anna, what's your dream randomized trial?
Well, my dream would be to have this money, to have someone to design lots of material, educational material for each different learning style.
So like a systematic assessment of learning style, material specific to that.
And then I would have like high technology video games and, think about it and have it one group training as we do it, assessing informally and training, and the other one with very specific material for that style. So I would have like games for the motors one. I would have video that they could replay at home. We can have like podcast teaching the steps for the bag exchange. So it have very specific tools for each group of learning style. And the other one, we would just ask the patient, how do you learn, and trying to incorporate and see how long we would take the training time, and the outcome would be infection, would be training time and infection as the outcome. That's my dream in research.
That's interesting. That's really great. So lots of exciting areas for people to focus on. And then again, I'm just going to put a plug for you. And I know you're doing a survey about masking. So if anybody's listening and has not done the survey, please look out for it. And again, that's also something that's quite variable, whether we mask to do exchanges or not. Some countries and some centers do, some don't. And the evidence base is not strong one way or the other. So a survey would be really good. And again, another study on that, I think, would be really practical and interesting.
I think we'll wrap up now. Again, thank you so much, Dr. Chow, Dr. Figueiredo, for this direction paper. We will definitely look forward to having another episode in a similar vein with all the technology we just talked about incorporated into another position paper soon, hopefully.
With the randomized trials that we'll do.
With the randomized trial, with the dream RCTs.
Right.
Just let's transfer the $1 million to us first. We will.
Right.
You said 5 million.
If anybody out there is listening, please, we welcome your donations to these randomized trials.
Please. This
is awesome. So thank you so much, everyone.